would like to thank both the royal family and the government of Dubai for inviting Chris Coburn and myself here to address you on this topic that we are both very passionate about. And it has been a terrific experience for both of us so far to be here with all of you today. So as a venture capitalist for 30 years, we always used to define innovation in terms of technology. We thought that innovation meant a new drug or a new medical device or some kind of new technology. But today, innovation in healthcare means much more than that. First of all, it means innovation is positive change, change moving forward. So today in the United States, we are innovating the way that we organize and pay for healthcare. And maybe the most important innovation happening in the United States in healthcare today is actually not in technology, but in the way that the government organizes and pays for the healthcare of its citizens. There is obviously a lot of innovation today that is happening in information technology and the use of information technology both in the hospital, in the doctor's office, and this is very important, in the patient's home. So today, innovation means much more than it meant in the past, and healthcare innovation today, very exciting topic because you look at the services, you look at the use of computers, you look how we pay for things, and you look at new drugs, new treatments to cure diseases.
Yeah. Mr. Coburn, if I may ask you, what do you think are the areas that has potential for innovation?
Well, thank you, and I just want to echo Jonathan, my great gratitude to being invited by His Excellency and the conference organizers. I think if you look at the U.S. healthcare system, just picking up on what Jonathan said, the things that are going on that are most significant is one, a massive transformation is occurring. In the U.S., it's been talked about for 20 years, but it is finally happening. So there's a consolidation occurring. And then you have a convergence of roles. So things the pharmaceutical industry used to do, much of that's happening in academia. You have more collaboration between the government and the private sector and the academic world. Probably the most important thing is, as it relates to innovation, is the combination of roles of the physician and the patient. So much of what used to be done by the physician is now occurring with the patient. So we see, and this gets back to the comments Klaus Schwab made, the roles have, to a degree, come together, and this is this systemic innovation, I think, mostly characterizes the system in the U.S. right now.
Mm-hmm. So do you think, like in 10 years, there won't be a doctor? All of them, I mean.
Well, great. There will always be plastic surgeons.
We don't need that.
But today there are 6,000 hospitals in the U.S. There's a theory that in 10 years there'll be 600. Some people would say even less, 60. Other people would argue there'll be 60,000 places where care is delivered, things that look like hospitals. So the system is disaggregating in a way and will come back together in a different fashion. So again, systemic change is probably what characterizes things the most, although as we discussed before, it's not to say scientific innovation has gone away. It still continues to a degree unabated, and we can talk about that more too.
Yeah. Jonathan, in diseases, treatment of diseases, where do you think the breakthrough is?
So the most exciting breakthroughs today in diseases are probably first and foremost in the field of cancer. The United States government declared war on cancer more than 30 years ago, and it has taken us a long time. It's sort of like the Samsung executive who was speaking. There was a vision that we would one day be able to defeat cancer, and for many years it looked like it was an impossible vision. But today in the United States, there are more than 5 million women walking around who have been diagnosed with breast cancer and who have survived and can expect to live to the rest of their life. I myself am a cancer survivor. I was diagnosed 8 years ago with a melanoma and treated actually at the hospital that Chris Coburn works at. And today I am now 8 years out on my diagnosis. So the changes that are occurring in the treatment of cancer are profound. And it means that instead of being a death sentence or a sentence where you're going to have to undergo horrible treatments and lose all of your hair and really not have very much fun for the rest of your life, today the diagnosis of cancer does not have to be a death threat. It can be the beginning of a process of treatment that results in many, many more decades of long life. So I think this is the area where people can have the most hope today about living a longer life than they were before. Certainly in the field of heart disease, an area that when I was born, most men would not live to see their 60s. And millions of men died of heart attacks in their 40s or 50s. Today, that number is very, very small. And there are all kinds of clever little devices that we can insert up into the heart to fix your heart for many, many different kinds of problems. We can keep all of your arteries open with bare metal stents. We can go inside and replace the valves that keep your heart and blood pumping and allow you to live into your 80s or 90s or even past 100 with a healthy heart. So these are just two examples of areas that are really enormously better than they were even 5 or 10 years ago.
And Chris, what do you think?
I would just add, I completely agree with the 2 points Jonathan made. Diabetes is a huge problem worldwide, in MENA, in the US. So a whole set of technologies are fast moving into the field from the, the molecular level, but also information technology. And then neurodegeneration, while trailing the other fields in terms of the level of innovation, there's been some important breakthroughs recently. And if you look at the economic forecast in countries like the US, there has to be some substantial innovation in the neurodegenerative diseases, or there's going to be a huge economic issue to work through.
Yeah. You talked about disease treatment. What about disease, the delivery of the service? Is there a breakthrough in it?
Well, yeah. So as we talked about before, and I think this panel has a big focus on, the use of information technology, and every speaker's already touched on it. Of course, Samsung, we have multiple dialogues going with Samsung. I'd love to catch our speaker, as a matter of fact. But whether it's connected health, where the patient gets new tools, where they can be more actively involved in their care, whether it's the use of big data, the ability, I was on the board of a big data company that's gotten a fair amount of attention in the US. They can do in 2 weeks what used to take 5 years of research and save tens of millions of dollars. So big data, and then the growing ubiquity of electronic medical records in the US. About 50% of the hospitals in the US are now fully developed on that front. And as the system becomes more widespread, the new capabilities will emerge that just have not been possible before.
Yeah. Jonathan, they say that like in 2010, most of the children that are born this year will live to 100. So, I mean, is it a burden on the health system?
Oh, this isn't a question that I could spend the rest of the session answering. But I just wanted to give an example of what Chris talked about that might bring it home to you, the change that's occurring in the United States. So when I was raising my children, who are now in their 20s, but then they were 2 or 3 or 4 years old, anyone who has been a parent can remember the child screaming, and you think that they might have an ear infection, and so what do you do? So 20 or 25 years ago, you had to call the doctor, and you had to make an appointment, and the person on the other end of the phone told you, oh, I'm sorry, there are no appointments available today. And then you would go into the phone, you would say, but my child is screaming, please, I'll pay you extra money, whatever it takes, make this child stop screaming. And today what happens is actually quite different. You can go down to one of thousands of CVS or Walgreens stores, and you can have a nurse practitioner look into the ears of your child, and she can, or he can, then immediately make a diagnosis. You don't need an appointment. You just go down to your local store, 1 or 2 or 3 blocks away, and then they can actually give you the medicine. You don't need to see a doctor. She is capable of writing a prescription for amoxicillin, which can be then used to treat your child's earache and stop the screaming. So the ability of, just in this one simple example, of parents to interact instead of with a doctor who's far away, but with many, many, many different healthcare professionals. So this is going to be extremely important when we start thinking about the treatment of all of the elderly people that we have in the United States. So just to give you an example, today, before we even think about the future, we have 18 million people in the United States that are over the age of 75. If you reach the age of 75, you almost certainly can expect to reach the age of 85. Of those people, more than half of them live alone by themselves. Only 1/3 of them are connected to the internet. All of them have various kinds of healthcare issues that require them to see a doctor. If all 18 million people went to the doctor at the same time with their problems, we do not have enough doctors. We do not have enough hospitals. And therefore, innovation today in the treatment of the elderly population is focused on 2 kinds of things. So the first is people. So we are rapidly innovating in the United States with people who are trained to go out into the community. So in this case, the healthcare system comes to you as opposed to you coming to the healthcare system. These people can be community care workers, they can be nurses, but one of the things that they have with them is they have one of these. And connected to one of these or their phone is a doctor on the other end of the line. And so it turns out that one doctor working with many, many different nurses or community care workers can actually make many, many different visits to many, many different elderly people, whether they are living by themselves or whether they are living with their families. Another very important innovation in the use of technology with elderly people is how do you know if they are doing well or not? In the United States, perhaps unlike here in Dubai, as I said, many of these people live by themselves. So if you are the son or the daughter, how do you know if your mother or father is doing well or not? And there has been wonderful innovation, numerous companies getting started in the United States that have different ways of keeping track of whether or not your parent is doing well. They can track how many times they turn on the TV, how many times they make coffee. They can track if they're walking around in their apartment. They can even track if they're falling or not. One of the most fun innovations is a robot called Beam. And Beam is described as a Segway, which is the thing on 2 wheels, with an iPad on it. And you can sit in your house as the child, the son or the daughter. You can drive the robot around your mother or father's house and look at actually how they're doing. So we have in our country, and I believe in every country in the world, an enormous challenge in how to take care of this elderly population that exists today. The problem is, in every country of the world, the number of elderly people will grow and grow and grow, and the number of young people that take care of them will shrink and shrink and shrink. And this is going to be the major challenge for governments over the next 20 years.
Chris?
So category in U.S. healthcare that Jonathan's talking about is referred to as population health management. So earlier I mentioned this idea of convergence. Basically what you're saying is you're bringing sophisticated medical technology into the home. And a very interesting flip side of what Jonathan said is, for a certain portion of the U.S. population, for the first time in 100 years, they will have lower life expectancy than their parents, and that's folks who are suffering from obesity and diabetes. So, while we have a mandate for the elderly and in every way that Jonathan's describing, we also have a desperate need for innovation as it relates to dealing with that cohort, which is growing in the U.S. And to a degree unresolved. And the epidemiologic forecast is actually quite sobering as it relates to that portion of the U.S. population.
Do you think the innovation in the geriatric part will increase since the aging population increases?
Well, yeah, and I agree with the points Jonathan made. I think, just getting back to something you had raised, Dr. Almala, the mechanisms of care are changing. So, for instance, when I was at Cleveland Clinic, we used an international call center to reach out to all the patients, the heart failure patients that had been admitted in the hospital, to try to avoid readmissions. And principally these are geriatrics, usually with multiple disease problems. So in this instance, kind of a lower tech solution where you were able to engage the patients by phone in a different way, that function had not been there before. That exchange with the patient just telephonically drove down readmissions rather substantially. So again, the model of care is evolving very rapidly in the U.S.
Jonathan, do you think innovation will reduce the cost?
No, unfortunately, I don't think that innovation is going to by itself reduce the cost that governments have to pay for healthcare. And there are a number of reasons for that. The best way to save money if you were the government is to have people die, because then you don't have to take care of them year after year after year. But in fact, the opposite is happening. People now are, as we said, living, whether it's in the United States or the rest of the world, for a much longer period of time. So I myself like to use the example of my mother-in-law. This would be my wife's mother. And she is living with her boyfriend. And her boyfriend is 91 years old. He actually fought in World War II. He is so old. So he lives a very active life. They go to the Caribbean, they go on cruises, they go out gambling, they have a wonderful life. There are many 50-year-olds that should have such a life as these two people. The reason he has this life is because he has 2 new knees. So he can walk only because of the new knees. So in the United States, every year now we put in 1 million new knees and hips in elderly people. And as more and more people continue to live, we will continue to need to replace spare parts. In addition, he has his entire heart system is held open with bare metal stents. So he would have died a long time ago were it not for the fact that his blood vessels are held open. Many people have their heart valves replaced now, actually in a procedure that only takes 1 day. And again, as people live longer and longer, your parts are going to wear out, and you're going to need new spare parts, just like a car that you want to keep driving further and further and further. And of course, my 91-year-old boyfriend of my mother-in-law also has glasses, he has hearing aids, he has a complete set of false teeth, and there's certain drugs that he also likes that help him keep my mother-in-law very happy. So he is a big fan of innovation, but he actually does cost the system a lot of money every year, and he will, because he draws Social Security, he goes and visits the healthcare system, and he is going to need all of these spare parts. So the trick is not so much to reduce the cost of caring for him, but how can he then also contribute to society? How can he help the economy grow? how can he make government revenues also not just a cost, but also pay something back? And of course, he does that by going out and participating in the various casinos or the restaurants or going to movies. He's part of the economy. So it's a very difficult thing to measure, this cost of people growing older. But I think it is not true to say, to promise you that innovation will reduce the cost, because innovation is going to make us all live longer. And when we live longer, we don't just want to live long, we want to live well. And living well means being active, and being active means spare parts.
Chris, your thoughts?
So I think in U.S. governmental policy circles, there's a risk of a false dichotomy there to suggest that there's expense and innovation juxtaposed with each other. Let's just take economic forecasters have been warning now for at least 2 decades about the pending, it's called the Alzheimer's cliff in 2035. And it basically is as cataclysmic an economic forecast as you could have. So think about that. What's the only way to avoid that, assuming, and I couldn't agree more with Jonathan, as a large portion of the US population lives longer, if you accept that as a given, then there's no way to get around the Alzheimer challenge without some innovation. So it's not like we're going to lay aside innovation and say, okay, we're going to stick with the status quo. We can't afford that in the U.S.
What do you think about smart city concept? I mean, a city that is prepared for the geriatric or the sick person?
Well, again, I think the instrumented home and workplace is just around the corner, and you had some great examples of that already this morning. In so many ways, information is being captured. Just the programs that are in the iPhones or the Samsung devices of today are providing things that are influencing the lives of people and making them healthier. So it's no stretch at all to see that in the future. I think the question is, how do you integrate that into a care path? So you've got an interface between what the individual is capturing in their daily life, whether it's through passive sensors in their house or through handheld devices, getting that into let's say a medical management program, and that's still a little bit in the future.
Mm-hmm. Jonathan, I mean the aging population is increasing. Don't you think there will be innovation in making them go back to work or creating some new treatment or something?
I think there must be. So I wanted to share a few statistics to support what Chris Coburn said. So today, Alzheimer's is actually risen to be the 6th leading cause of death in the United States and the 5th leading cause of death for anyone who's over 65. In the last 10 years in the United States, deaths from breast cancer have dropped by 2%. Deaths from prostate cancer have dropped by 8% just in the last 10 years. Deaths from heart attacks have dropped 16%. Deaths from stroke have dropped 23%. Deaths from HIV, 42% reduction. Alzheimer's, increase by 68%. So as we continue to find ways of curing cancer or of treating heart disease or diabetes or stroke, certainly HIV, the great challenge, which Chris mentioned for governments, for families, is going to be Alzheimer's. So the way that, I said, I think that governments are going to have to rethink what it means to be an older person. So one of the really nice stories I heard last night was actually about the father of my colleague here, Mr. Coburn. And he told me that his father had been a doctor and had worked for 40 years as a heart surgeon treating patients. And then he retired on the day he was 65. But he did not stop. He went back to college. And he went back and did he get another degree, Chris, or did he just take a bunch of courses?
The latter.
The latter. So he took a bunch of courses, but One of the really interesting experiments going on in a college right near where I live is they have decided, in addition to the students who are in their 20s, they've also opened up their campus and they've built an old folks home. It's a place where older people live on the campus directly with the students. And they've also brought in a daycare center where parents bring their children to be taken care of. And the older people participate in classes. They also help take care of the children. And you can imagine that these kinds of people who are engaged in taking care of children, engaged in using their brains to learn, are going to have a much longer and happier life. And Chris, I believe you told me your father is still alive. He's 93 years old. And it sounds like a wonderful relationship between father and a son. And that's actually something that we should all hope for. So I do believe that the governments have to rethink what they're going to do with these people who are going to live for decades beyond the age of 65. So bring them back to school, put them to work taking care of children, put them to work helping in every aspect of the delivery of government services. These are people who are wise, they are experienced, and they want to give something, they want to be part of society. They don't want to just live alone by themselves. So I believe that this is a fundamental challenge for government and society, not just to keep people living longer, but to make sure that that life is a high-quality life.
Yeah. Chris, I mean, like stem cells is a very hot topic now. And do you think that in the future we can create an organ or something with stem cells?
Well, absolutely. There's no question. Probably, I got to look around the room here. At least in the lifetime of people in this room, stem cell will be part of the therapeutic approach to disease. Will it be in the next 10 years? At least in the U.S., there's a lot of complexity. Actually, Korea's had, in some categories, a lot of leadership in this field. But I was associated with a company that just is going to announce, hopefully very soon, successful results for cardiac stem cell technology that has improved heart function. And I bring that up just because literally tens of billions of dollars have gone into that exact category, using stem cells to improve performance of the heart. Possibly the corner has been turned here. But it's still, you look at the big centers, a guy in Wake Forest in North Carolina, Tony Atala, gets a lot of worldwide coverage. But getting that into the clinical mainstream, at least in the US, is many, many years away.
Jonathan, who's financing the innovation in the state? Is it the private sector or the government sector?
So one of the things that works particularly well in the United States is how we do finance innovation. So today, the United States government spends about $40 to $45 billion a year in fundamental research. So this is not research that is used to invent new products. It is just research that is used to advance knowledge. We then have a very large private investment sector. So in the United States, the venture capital industry that I was part of for 30 years spends about $30 billion a year in starting new companies. And that is just the formal part of the venture capital industry. You obviously also have many companies like Samsung you heard before, but certainly the large pharmaceutical, medical device companies, they are investing a great deal of money in the research and development of new hospitals. And finally, it's become quite popular in the United States for wealthy individuals, the so-called super angels, to make new investments in companies. So I am a director of several companies whose financing comes not from the government, whose financing comes not from a venture capital fund, but comes from a private family that has decided to use some of their wealth for improving society, and to do that by financing innovation. So we are very fortunate in the United States to be able to draw upon all of these different sources, and they work collaboratively together to advance this innovation. And it's very expensive. It costs in the United States about $2.5 billion for a new drug to go from an idea in a university or a hospital all the way to the time when the US government approves it. And it takes about 15 years. The development of some of these products that I mentioned to fix your knees or fix your heart can still take hundreds of millions of dollars of product development and testing along the way. So the financing of that does not come from the government in the United States. Almost all of it comes from the private sector that is either investing for purposes of making a financial return, or it comes from corporations that are investing to try to develop a new product, or it comes from wealthy individuals who would like to advance society and just contribute to the betterment of mankind. So we're very fortunate we can bring more than $100 billion to bear every year just in developing new products in healthcare.
So Jonathan just described, let's call it the classic categories of innovation. I think sometimes folks overlook what's orthogonal to that when we talk about the role of government in the US, is government as payer. The US federal government by far is the largest payer for healthcare in the world. I think the spend for the US federal government last year was about $600 billion. So they determine what gets paid for. So if you are trying to bring a new product to market and you do not have a prospect of reimbursement by the US federal government, your innovation will not advance, no matter what the category is. So that's one thing. And I think a little more subtlety and of really great interest, and this is what's occurring right now in the US healthcare, is the US government as standard setter. So when you look at the Affordable Care Act, Obamacare, it has created standards where they didn't exist before. So you look at the hospitals I work for, the Harvard hospitals, lots of innovation over the decades, going back to 1812 when Massachusetts General was created. But much of that innovation in terms of the systems, the procedures, stayed local within the hospital. Now the US federal government has created, just in the last few years, a standard for readmission of heart failure patients. I touched on that before. So as we develop new technologies to help our heart failure patients not come back into the hospital, every single hospital in the US cares about that because they are required by the standards the US federal government set to drive down their readmissions. And that's across dozens and dozens of categories. So it's very interesting to see how in a slightly less obvious way, innovation is influenced by government in the US.
Jonathan, you spoke about cancer and innovation in cancer. Mm-hmm. Do you think it's detecting cancer or treating cancer, or what will be the innovation?
So this is an innovation which is ongoing right now, and I guess I would like again to start with a personal story. So I mentioned that I am a cancer survivor, and my mother was died at a very young age, at the age of 33, from breast cancer. So my daughter, who shares my fair hair and obviously my genes, is at great risk for, we worry that she would be at great risk for cancer herself. And you've read about famous actresses that have had surgery to prevent cancer. But in this particular case, in the United States, we have made a great investment in genomics. So one of the great accomplishments that I have been part of in my career is to finance the companies that have been made it possible to actually quite cheaply sequence a genome, to sequence the genes in each and every one of us. Today, we can sequence each one of you for less than $1,000. What is much harder is to learn what the genes mean. What does it mean when you have a gene for X or a gene for Y? Well, in the case of breast cancer, we actually know quite a bit. Today, we know there are 9 different types of breast cancer based on the different types of genes that you have. And we know that in a few more years, we'll be able to expand that to, instead of saying that you just have breast cancer, you have maybe one of 40 different subtypes. So what happened is that about 4 weeks ago, before I took the trip here, my daughter went to a laboratory, and her blood was drawn, and she was sequenced. Her genes were read out by one of those machines. And we got a report just before I got on the airplane to come here that said of the 28 genes that we know lead directly to breast cancer in women, very fortunately, she does not have a positive case in any one of these. So you can imagine just the joy that we felt in our family. But this is just one example of millions that is happening every day in the United States, where three things are going on. So first, we have this ability to sequence and gather all of this data. Chris mentioned in his remarks that big data is then the ability to take all of this genetic information and correlate it with what's actually happened in the past with different kinds of patients. So we know that patients with certain kind of genes get cancer, patients with other kinds of genes don't get cancer. And then the next big, really interesting thing that's happened is that we've been able to take the treatments of certain drugs and understand that in this particular patient, a positive gene will make it possible for the drug to work, and in these other cases, the drug will not work. So just again, to give an example that's well known throughout the world, there was a drug that was invented for colon cancer, and it only worked about 15 or 20% of the time. Until through genetic sequencing, we identified the gene that the drug works on. And today, if you are a colon cancer patient and you have this positive for a KRAS gene, you will in fact have an 80% chance of recovery and survival. And if you don't have the gene, the positive, then the drug will not work for you. So we're entering a very exciting age where customization to the individual, precision medicine or personalized medicine. Some of you may have just read that, in fact, President Obama has dedicated a new $250 million research program to accelerating the discovery of these genes that lead to specific cancers and then the identification of drugs to target that specific cancer. So this is the area right now where we can see the benefit of the investment that was made in research in the past 20 or 30 years. And every cancer for men and for women over the next 10 or 20 years is going to go through this process. And your children will, in the future, understand their genetic sequence. They will understand what cancers they are at risk for. We will start screening for those cancers early, and we will develop drugs that just work specifically on those genes. So never has there been greater hope for patients with cancer than there has been today.
So just maybe amplifying that a little bit, you know, some cancers have virtually been cured in the U.S. You look at childhood leukemias, ALL, testicular cancer, 96% cure rate. So as we better understand these genomic mutations, we have the opportunity to head-on resolve some of these diseases. So as an example, one of our hospitals, Brigham and Women's, just finished an analysis of 5,000 patients and determined that 26% of the patients studied had what they refer to as an actionable assessment. So now, you know, you're taking this, all these technology tools, information technology tools, and drilling into things that then could ultimately, not today, but result in dramatic advances in care. I think just getting back to the earlier point about systemic innovation, it's worth keeping in mind in the US that most cancer care is delivered in a non-hospital setting. And consequently, the uniformity of quality varies dramatically. So no matter what the technologies are, no matter what the diagnostic capability, if you're not getting it delivered by someone who's expert in the field, you're not getting the full value of innovation. So as you look at these information technologies, you know, really the future of health IT in the US is as these powerful tools, whether they're electronic medical records or genomic analysis, the so-called precision medicine, gets into the basic workflow of how healthcare is delivered. So the vision is that all cancer care will improve in the US as the lowest level gets raised up, hopefully close to what you would get at a large academic medical center.
Do you think the 3D printer will be, I mean,
it's just like cell therapy. It certainly is there. It's there now on the design end, whether it's printing on cellular.
Printing a whole organ or something.
Yeah, that is occurring, essentially occurring today. Maybe a quicker use of the technology is to be able to customize, let's say, orthopedic implants, or model a particularly difficult brain or heart surgery for the physician at a time. So yes, 3D printing has arrived, not fully clinically, but I'm sure in your specialty. I mean, you think about cosmetic fillers. There's a company that we do some. One of the folks on our team actually was the #2 person. An orthopedic company making customized patient-specific implants. And that's today, and you could be doing that with 3D printing remotely. You just capture the 3D image, ship it off to anywhere really in the world and have that show up a day or two later. So that's occurring in current practice.
Jonathan, if we meet again in like 10 years, what do you think, what is the change? What will be the change?
Oh boy. So, well, first of all, if we meet in 10 years, we're all going to be not having to carry around our phones because they'll be embedded somewhere in the clothes that we wear. And there will be all kinds of information about what we eat or what we're walking that will be available to us. So it's really incredible to think of. But I think that the thing that will be most amazing to us will simply be how much information we have about ourselves. So 10 years from now, all of you will know your genetic sequence. And you will have some idea of what it means in terms of forecasting your future. And you will have probably some kind of personalized health program. So instead of being treated just like all men who are 47 or all women who are 39, your health program will be customized for you, for your genome, for your background, and for your wishes. What kinds of lifestyle do you want? What kind of risk are you willing to take? So that will be certainly the biggest change in 10 years, is just this amazing amount of information about yourself and the translation of that into a custom health plan. And you will probably go to the doctor in 10 years, not so much because you are sick at that moment, but you will go to a doctor to say, look, I have this is who I am, I have this genetic background. The things that are important to me are long life and family, and maybe you want to be very active in sports, for example. And you will work out with your personal health coach the kinds of diet, the kinds of activities that you need to pursue in order to live a long and healthy life. And because human beings often go to the doctor and then they get the information, but they're not very good at doing it, just like a diet. We all start a diet and then have a hard time keeping going. But in 10 years, you're going to have this little voice somewhere in your coat. And as you are reaching for that extra ice cream or reaching for that extra piece of cake, some little voice in your coat or your pants or your glasses is going to say to you, Jonathan, your health plan says you should not be doing that. You're already 10 pounds overweight. This is not good for you, so you need to stop. And I think that there will be this interaction between just the information and your health plan and reminders and helpers to help you actually live that lifestyle. Hopefully it will not be my children saying, Dad, don't do that.
Chris, if I may ask you the same question.
So a couple quick thoughts. One, I think, and I was I don't know if I mentioned this yesterday, but I was on one of the advisory boards on the Watson program for the healthcare applications. So what will be most different in terms of the delivery of care 10 years in the future is today, a physician or a nurse has to, in a fairly clumsy way, access data to support a decision, to somehow or another inform a choice that has to be made. In the future, that's going to be just built into the workflow of how a physician or a nurse interacts with a patient. It'll be completely intuitive, and those care paths will be mapped out in a way that require no second thought. So I think that's important. And the other thing I would say, later in April, we're going to have the World Medical Innovation Forum in Boston. We'd love to have folks come. The focus will be neurosciences. And much like Davos, we hope to assemble people from around the world to talk about what healthcare will look like 10 years from now.